Imagine going to your doctor because you feel this really distressing sense of physical looseness,
Right.
like a total lack of support, only to be told that your internal muscles are actually locked in a state of paralyzing tightness.
Yeah, it's wild.
Welcome back, learner, to the deep dive. Today we're looking at a huge stack of NHS guidelines, pelvic physiotherapy clinic guides, and the latest medical literature.
Some really fascinating stuff in there.
Definitely. And we're exploring an incredibly complex, yet rarely discussed medical mystery today. We are taking on a very specific question.
Yeah.
Can internal scar tissue, which is known as pelvic adhesions, actually create pain and altered sensations that women mistakenly interpret as laxity or, looseness?
I mean, it sounds completely counterintuitive, right? That
Right.
something pulling you physically tight on the inside could somehow make you feel loose on the outside.
It makes no sense at first glance.
No, but the human body is, well, it's a master of misdirection. And when it comes to the pelvic floor, the signals we feel at the surface are very often masking a much deeper mechanical failure.
Okay, let's unpack this. Because to really understand how a tight internal scar can mimic looseness, we first have to establish what laxity actually is in a medical sense.
Right?
And probably more importantly, what it isn't. Because looking through these clinical guides, patients, and even some general practitioners confuse a feeling of laxity with a completely different structural condition.
They do, all the time. The first major distinction to make here is between vaginal laxity and pelvic organ prolapse, which you'll frequently see referred to as POP in the literature.
Right, POP.
Yeah. And they are routinely conflated in everyday conversation, but medically speaking, they're entirely different events.
Okay, so break that down for us.
So, pelvic organ prolapse is an anatomical structural failure. It is the literal physical descent of pelvic organs.
So we're talking about like the bladder, the uterus.
Exactly. The bladder, uterus, or the rectum. They physically drop down into the vaginal canal.
Wow.
And this happens because the ligaments and the fascia holding those organs up have fundamentally weakened or torn.
Reading through the literature, the visual that came to mind was a house with a sagging roof.
That's a perfect analogy.
Right, like the internal scaffolding of the house simply gives way.
Yeah.
And gravity just takes over.
Yeah, exactly. Gravity wins.
So with a prolapse, the patient is physically feeling a bulge or this heavy dragging sensation because an organ has literally shifted out of its designated anatomical space.
Precisely. The scaffolding has lost its structural integrity, and a doctor can actually see it on an exam. They can measure the descent.
Okay, so that's structural.
Right. Vaginal laxity, on the other hand, is completely different. It is a subjective sensation.
Subjective, okay.
Yeah, it's a feeling of reduced tone, like a loss of grip or a sensation of openness that a patient usually notices during intimacy or sometimes during physical exercise.
But nothing has actually fallen.
Exactly. You can experience severe laxity without any structural prolapse whatsoever.
That's fascinating.
And conversely, you can have a measurable prolapse without ever feeling a sensation of looseness.
Okay, so if laxity is just this subjective feeling and not a structural collapse like our sagging roof analogy,
Right.
what's actually generating that sensation? The sources point to hormonal shifts, right? Specifically, genitourinary syndrome of menopause.
Yes. GSM.
Yes, GSM is a very tangible biological driver for that subjective feeling.
Okay.
When estrogen levels plummet during menopause, the vaginal and vulvar tissues physically transform.
Because estrogen is doing what exactly?
Estrogen is essentially what keeps those tissues plump, elastic, and well hydrated. So when it disappears, the collagen fibers in the tissue begin to fuse together, and the elastin fibers actually fragment.
So the tissue itself is changing.
Completely. The tissue becomes much thinner and loses its stretch. But wait, how does tissue becoming thinner and less stretchy translate to a feeling of looseness, though?
Yeah.
Wouldn't less stretch mean it feels, I don't know, tighter?
Well, think of a standard kitchen sponge.
Okay.
When it's wet and hydrated, it's thick, bouncy, resilient. If you squeeze it, it pushes back against your hand.
Right, it has that resistance.
Exactly. That is healthy, estrogen-rich tissue. Now imagine that same sponge completely dried out.
Oh, it gets all stiff and shrunken.
Right. It shrinks, it becomes stiff, and if you press on it, there is no bounce back. It just stays compressed.
Wow, okay.
When the vaginal walls lose their hydration and elasticity due to a lack of estrogen, they lose that bounce back. They lose that grip.
So the patient perceives that lack of resilient contact as looseness.
Exactly. It feels like a hollow sensation because the tissue itself has fundamentally altered its composition.
Okay, so if a patient is navigating menopause, the hormonal side Completely explains the physical change in the tissue's texture. But what if a patient hasn't hit menopause? What if their estrogen levels are totally fine, they don't have a structural prolapse, but they still feel this intense sensation of laxity?
Right, that's the big mystery.
What is the brain misinterpreting there? I mean, couldn't it just be normal aging?
It's often written off as that, but this is where we have to look behind the curtain at the hidden culprit that's distorting the pelvic floor's mechanics.
Okay.
When a sensation of laxity persists without a hormonal or structural cause, it is very often a false alarm triggered by pelvic adhesions.
Adhesions. So we're talking about essentially internal scar tissue, right?
Yes, exactly.
But before we get into how they cause this false alarm, what exactly is happening in the body to form them in the first place?
So they are bands of fibrous scar tissue, and they develop as a flaw in the body's natural healing response.
A flaw.
Yeah. Whenever there is trauma in the pelvic or abdominal cavity, the body triggers a biological cascade to stop the bleeding and repair the damage.
Okay, that makes sense.
Platelets arrive at the injury site and release proteins, primarily one called fibrin.
Fibrin.
Right. This fibrin acts like a sticky temporary mesh to hold the wounded tissue together while it heals.
It's like the biological equivalent of throwing down a tarp and some duct tape over a leak.
Precisely that. It's a quick fix. In a perfect scenario, once the permanent tissue underneath repairs itself, the body sends in specific enzymes to dissolve that temporary fibrin mesh.
The cleanup crew arrives.
Exactly. The cleanup crew removes the scaffolding. But in the highly enclosed environment of the pelvis, that cleanup process often fails.
Oh.
The fibrin is left behind, and it organizes into tough, permanent scar tissue. And here's the problem. It begins to connect organs, muscles, or fascial layers that were never meant to be connected.
And looking at the sources, they list a lot of different traumas that can kick off this fibrin cascade. Surgeries, obviously, like C-sections, hysterectomies.
Yes, those are major triggers.
But they also mention episiotomies. And just to clarify for those who might not be familiar with the term, an episiotomy is a surgical cut made at the opening of the vagina during childbirth to aid delivery, right?
Yes, an incision through the perineum. And even a natural perineal tear during childbirth triggers the exact same fibrin response.
Wow.
The trauma can also come from internal infections like pelvic inflammatory disease, or chronic inflammatory conditions like endometriosis.
Where the body is just in a constant state of wounding and healing.
Exactly. It's throwing down more and more of that sticky fibrin mesh.
The clinic guides describe these adhesions acting like an internal glue.
That's exactly what it is.
If you picture a complex moving machine with all these gears and pulleys, and someone just spills super glue inside of it.
Yeah, everything seizes up.
It binds everything together, restricting the natural fluid mobility of the organs and the muscles.
And the statistics on this internal glue are staggering. Data indicates that up to 90% of people who undergo an open pelvic or abdominal surgery will develop some degree of adhesions.
90%.
Yes.
Almost everyone who goes under the knife for a pelvic procedure is walking away with these internal scars.
Pretty much, yeah.
But if they are that common, why is it such a medical mystery? Shouldn't a doctor just be able to look at a scan and say, oh, there's the glue, let's go in and fix it?
You would think so. But the diagnostic challenge is immense because adhesions are soft, fibrous tissue.
Okay.
They simply do not appear on standard ultrasounds, and they are invisible on MRI scans.
Wait, invisible?
Completely. A doctor reviewing imaging is essentially flying blind regarding the scar tissue itself.
That is wild.
They might see secondary evidence like maybe an ovary is pulled slightly out of anatomical alignment, but they cannot see the web of adhesions causing the pull.
So how do they even know it's there?
Diagnosis usually relies on a highly detailed patient history and specialized physical exams where a physiotherapist assesses tissue mobility by hand.
Feeling for the restrictions.
Exactly. Or, as a last diagnostic step, a laparoscopy, where a camera is surgically inserted into the abdomen to visually confirm the scarring.
I am grappling with the core paradox here, though.
Okay.
If we have this internal superglue making everything rigid, tight, and stuck together, how does that physically result in a feeling of laxity or looseness?
This is the big question.
Right, because we have rigid scars on the inside, but a feeling of zero support on the outside.
Answering that requires looking at the neuromuscular response to pain.
Okay, the nervous system gets involved.
Exactly. When deep pelvic adhesions, or a perineal scar from childbirth, begin to restrict natural movement, They create an asymmetrical pull on the surrounding tissues.
Like tugging on a sweater.
Yes. Every time the patient moves, that internal glue tugs awkwardly, and that tugging causes pain.
Naturally.
When the human body senses pain, its immediate primitive reaction is to clench. The muscles of the pelvic floor reflexively tighten to guard and protect the injured area.
The body braces for impact.
It braces, yes. But the critical issue is that it never stops bracing.
Oh, wow.
This leads to a condition called a hypertonic pelvic floor. The muscle becomes locked in a continuous, involuntary state of spasm.
It's just permanently clenched.
Exactly. And because the muscle cannot relax, it consumes its energy reserves and becomes deeply exhausted. An exhausted muscle loses its functional capacity. It cannot contract efficiently when you try to use it.
Wait, let me piece this together with something from the reading.
Yeah.
The sources compared this pelvic floor reflex to a scared puppy tucking its tail between its legs.
It's a really good visual.
Right.
Yeah.
Humans have that same primitive fight-or-flight response. So if the body is essentially tucking its own tailbone to protect the internal scar, the tailbone physically moves forward.
Yes.
And since the pelvic floor muscles attach directly to the tailbone, if the tail is tucked, those muscles are forced to shorten. They are chronically clenched.
That is the exact mechanical chain of events. Now, consider the brain's role in interpreting all of this.
Yeah.
You have a tucked, exhausted, spasming muscle, combined with distorted sensory feedback coming from the scar tissue, pulling in all the wrong directions.
That's a mess of signals.
Total chaos. The brain is receiving a massive influx of scrambled signals. It registers a profound loss of functional movement, a lack of blood flow to the tight muscle, and just a generalized feeling of something is wrong.
And because the muscle is so exhausted that it literally can't contract properly, the brain translates that lack of function as a lack of support.
Exactly.
The patient experiences the scrambled, exhausted signal as feeling loose, even though the physical space is actually locked up tight.
You've got it. The functional weakness of a hypertonic muscle perfectly mimics the physical looseness of a stretched or torn muscle.
So it's an illusion.
It is a sensory illusion created by exhaustion and restricted mobility.
This brings up a massive red flag.
Oh, definitely.
Because if someone feels loose, the universal go-to advice, whether it's from an internet search or even a well-meaning doctor, is to do Kegel exercise.
Right, squeeze, squeeze, squeeze.
Exactly. Just do Kegels.
Yeah.
So if someone with a hypertonic pelvic floor driven by adhesions starts doing hundreds of Kegels, what happens?
It is actively dangerous advice.
Dangerous.
Very. Kegels are concentric contraction exercises designed to build strength in a weak, underactive muscle.
Okay.
If you demand more contractions from a muscle that is already trapped in a severe spasm, or if you force an exhausted muscle to pull harder against immovable, glued-down adhesions, you will rapidly exacerbate the dysfunction.
You're pouring gasoline on a fire.
Literally.
You're trying to tighten a knot that is already pulled to its absolute breaking point.
You will increase the pain, you'll drive the muscle into deeper spasm, and make the sensation of laxity even worse because the muscle becomes even more exhausted.
Wow. Okay, so we have physically tight tissues and exhausted muscles sending scrambled signals. But the literature points out that when this goes unresolved, the pain spreads.
It does.
It becomes chronic and overwhelming, which brings the nervous system fully into the equation.
When chronic pelvic pain persists, and clinically that's defined as lasting more than 3 to 6 months, we have to look beyond the local tissues.
Okay.
We have to examine the body's central alarm system. We enter the territory of central sensitization.
Central sensitization. The way the sources describe this, I pictured a hypersensitive car alarm.
Okay, let's hear it.
Say a car gets broken into, that's the original surgery, or the tearing during childbirth. The alarm is installed to protect the car from future damage.
Right.
But the wiring gets glitchy. Months later, the alarm starts blaring at top volume just because a leaf fell on the windshield or a truck rumbled by on the street. The actual threat is zero, but the sirens are deafening.
That's exactly how it works. In a biological sense, chronic pain physically alters the architecture of your spinal cord.
Physically alters it.
Yes. This is neuroplasticity, but working to your detriment. The glial cells in the spinal cord, which normally just act as a support system for neurons, begin to release inflammatory chemicals.
Okay.
These chemicals actually lower the firing threshold of your pain receptors.
So it takes way less stimulation to trigger a pain response.
Think of the pain receptors like bouncers at a nightclub.
Okay.
Normally, they only step in and raise the alarm when someone is clearly causing a massive disruption, like actual tissue damage.
Sure.
But in central sensitization, those bouncers become overzealous and highly reactive. They start throwing people out just for looking in the wrong direction.
Just reacting to everything.
Everything. The nervous system begins picking up every day harmless signals, normal digestion, the bladder filling, normal movement or intimacy, and the hyper-excitable receptors categorize all of it as a severe threat.
The brain genuinely perceives that the pelvis is under continuous grave attack.
It does. It is vital for anyone experiencing this to understand that the intensity of the pain does not equate to the amount of tissue damage currently occurring.
Wow.
Severe pain simply means your body's alarm system has become far too sensitive.
I have to ask the difficult question, though.
Go for it.
If the central nervous system is just misinterpreting signals and sounding a false alarm, does that mean the physical adhesions don't actually matter anymore? Like, is a doctor going to tell a patient that this is now all in their head?
It is a devastating disservice when patients are told it is just in their head. The physical adhesions absolutely still matter.
Because they started the whole process.
Exactly. They were the mechanical trigger that flipped the alarm switch in the first place, and they are still actively restricting organ mobility.
Right.
The critical takeaway is that treatment cannot be exclusively physical. An effective treatment plan must dismantle both the physical scar tissue pulling on the fascia and the brain's overactive threat response. Addressing one without the other guarantees the cycle will continue.
Which brings us to the ultimate question. How do we untangle this web? We have physical internal glue, exhausted hypertonic muscles masquerading as loose, and a nervous system stuck in overdrive.
It's a lot to deal with.
Where do patients actually start with evidence-based treatments?
The primary first-line treatment is decidedly non-surgical. It relies heavily on specialized pelvic floor physical therapy.
Okay.
And to be clear, this does not involve Kegels. The physiotherapist focuses on manual therapies, primarily myofascial release and targeted scar massage.
Before we move to the nervous system, what exactly does myofascial release look like in a clinical setting? How's that different from, say, a regular deep tissue massage?
A standard massage typically uses gliding strokes over the muscle belly to increase blood flow. Myofascial release targets the fascia.
The fascia.
Yeah, that's the continuous web of connective tissue that wraps around every single muscle and organ. It involves very slow, sustained pressure.
So no rubbing or gliding.
No. A specialized therapist might hold a specific tension on the vaginal wall or externally on a scar for several minutes without moving.
Several minutes. Wow.
They are waiting for the collagen fibers in that restricted fascial layer to physically soften, yield, and elongate, which gently improves tissue mobility without causing new trauma.
So they are slowly stretching the superglue.
Basically, yes.
And what about the nervous system side? How do you treat the overzealous bouncers? The sources talk about downtraining the nervous system.
Downtraining often begins with deep, diaphragmatic breathing. The diaphragm and the pelvic floor work together like a piston.
Okay.
When you take a deep, expansive breath into the belly, the diaphragm pushes down, which mechanically forces the pelvic floor to drop, stretch, and release its grip.
So you're forcing it to let go.
Yes. By consciously practicing this, you are manually signaling the vagus nerve that the body is safe. You're coaxing the nervous system out of fight or flight.
That's incredible.
Therapists also use biofeedback. They place sensors on the muscles so the patient can visually see their baseline tension on a screen. It teaches the brain how to actively let go of that chronic clenching.
What about the hormonal aspect we touched on earlier? If someone does have genitourinary syndrome of menopause contributing to that sensation of looseness, how is that integrated into treatment?
For GSM, localized topical vaginal estrogen is transformative. Oh, yeah. Applying estrogen directly to the vaginal tissue restores that wet sponge resiliency we talked about. It replenishes hydration, thickness, and elasticity.
So it brings the sponge back to life.
Exactly. It does not mechanically tighten the muscles, but it completely revives the tissue's structural integrity, which very often eliminates that hollow, lax sensation entirely.
I want to talk about the quick fixes, because the internet is flooded with them.
Oh, don't get me started.
There are countless ads for lasers, radiofrequency wands, and energy-based devices marketed specifically for vaginal rejuvenation and curing laxity. People pay thousands of dollars out of pocket for these.
Patients must exercise extreme caution here. The clinical guidelines are unambiguous. Energy-based devices are not standard care in the UK under the NHS for treating laxity.
Okay.
Furthermore, the FDA in the United States has issued stark warnings about these devices causing severe burns, scarring, and chronic pain.
Because they use heat. Right.
Yeah.
How does that actually damage the tissue?
These devices use controlled thermal damage to intentionally injure the tissue, with the theory that the healing process will provoke new collagen production and tighten the canal.
Wait, injure it on purpose?
Yes. But in a delicate, highly innervated mucosal environment, applying thermal trauma can easily trigger the exact overzealous fibrin cascade we discussed earlier.
So a patient paying to fix their laxity could be paying a clinic to burn their tissue, creating new adhesions, which then lock the pelvic floor into a hypertonic spasm.
Yes.
They're literally buying the exact pathology they're trying to escape.
It is a profound risk of engineering the very dysfunction you are attempting to cure.
Man, if the non-surgical physical therapy route fails, what about going back in surgically? The procedure is called adhesiolysis, which essentially means the surgeon goes in and cuts the scar tissue away.
Right.
But applying the logic we've just uncovered, doesn't opting for surgery to remove scar tissue just trap you in an endless loop of creating more scar tissue?
Your deduction is exactly why medical guidelines mandate conservative physiotherapy-led approaches first.
It just makes sense.
Surgery is, by definition, a trauma. Cutting out existing adhesions inevitably sparks the body's fibrin healing cascade all over again.
The cleanup crew fails again.
Exactly. They are just as likely to fail the second time, leading to the formation of new and sometimes much denser adhesions.
So it's not a silver bullet.
Not at all. Adhesiolysis is considered an absolute last resort, reserved for critical situations like a bowel obstruction or when intensive physical and neurological downtraining have been entirely exhausted.
It really is a delicate ecosystem down there. You cannot just hack away at it and expect it to reset.
No, you really can't.
Looking at our mission today, we have completely inverted the concept of vaginal laxity. What feels like a structural weakness, a lack of support, or an embarrassing looseness can actually be a complex matrix of rigid internal adhesions, spasming, exhausted muscles, and a nervous system that is trapped in a glitchy alarm state.
It perfectly highlights why symptom management in pelvic health must address the entire system: the mechanical restrictions, the muscular exhaustion, and the neurobiological threat response.
To you listening right now, dealing with pelvic pain or silently worrying that you are feeling loose, remember that knowledge is your greatest tool.
Absolutely.
You now know that the answer is almost certainly not doing 1,000 Kegels a day. You know to look beyond the initial sensation, to trust that the discomfort is not in your head, and to seek out a pelvic floor specialist who understands the vital connection between internal scars, muscle exhaustion, and central sensitization.
The path to relief is untangling the entire web, not just pulling at a single thread.
I want to leave you with a final thought today, something to mull over after you finish this deep dive. If our bodies are capable of rewiring their sensory feedback so drastically to the point that we can interpret intense, paralyzing tightness and internal scarring as looseness and weakness, what other physical or even emotional sensations are we completely misinterpreting in our everyday lives? We'll see you next time.